We'll get started here in about 2 minutes, folks, in about 1 minute now. It's 10:59 Eastern Standard Time. All right. It is 11 a.m. Eastern Standard Time, so let's go ahead and get started. So my name is Jamal. I'm the Executive Research Coordinator for the Surgery Medical Specialty Interest Group. So I thank you all for being here early on this Saturday morning. We have an exciting day of presenters planned for you. The Research Symposium is split up into two parts. So number one, we'll have the presenters present their research with a 5 to 8 minute time. After all the presenters are completed with their presentations, we will have a Q&A session. So if you have any comments, questions, concerns, please definitely write those down either in the chat box and we'll get back to you, or you can save them and write them down on your own and ask the presenters at the end of our presentations. Without further ado, I'm going to let one of our presenters, Miss Nicole Arriga, get started. So I'll let her share her screen. And if not, I'll let one of our other moderators. So I am one of the moderators as well as our wonderful president, Miss Rachel Herenshar. So without further ado, let's go ahead and get started.
Hi, everybody. Good morning, everyone. I'm Nicole Arriga. Thank you for the opportunity to present my research today, titled Closing the Gap, Analyzing Disparities in Breast Reconstruction Treatment Access. But first, imagine a world where every woman, regardless, can you guys hear me? Sorry, I'm like echoing. Okay. But first, imagine a world where every woman, regardless of her race or ethnicity, has equal access to life-saving breast cancer treatments and the opportunity to choose the reconstructive method that best suits her needs. Next slide, please. Breast cancer, as we know, affects women of all races and ethnicities, but disparities in healthcare access persist, specifically regarding breast reconstruction. Our study aimed to investigate the impact of race and ethnicity on the type of breast reconstruction chosen. In other words, how do these racial factors impact the access to different reconstructive methods? By understanding the patterns and disparities revealed in our study, we can take significant strides towards achieving equitable and personalized care for all breast cancer patients. Our findings have the potential to challenge current practices and ignite a call to action to bridge gaps and access to breast reconstruction, ensuring that no woman is left behind. So let's explore these findings together. Next slide. So for our methods, the University of Pittsburgh Medical Center Magee Women Hospital database was queried from 2011 to 2022. Women who underwent breast cancer surgery during this time were included in the study using demographic characteristics such as race, ethnicity, age, histology, behavior, best HACC stage, and reconstruction type. Results, please. Next slide, sorry. So the results in our study included 13,260 women who were diagnosed with breast cancer, of whom 1,763 women underwent breast reconstructive cancer. As you can see in the slide below, the figure shows the reconstructive rate breakdown by race. So of the 1,763 patients who underwent breast cancer reconstructive treatment, 92% were white patient, 7% were Black patient, and 1% were others. Next slide, please. So among the patients who underwent reconstruction, 46.8% had implant reconstruction, 30.1% had autologous reconstruction, 18.7% had combined reconstruction. Autologous reconstruction was seen to be more prevalent among Black patients at 36.3%, compared to 32.2% for implant reconstruction and 26.4% for combined reconstruction. So as we can see, white patient had also a higher proportion of implant reconstruction at 48%, while autologous reconstruction accounted for 29.5% and combined for 18.2%. Among other races, we're looking at Asian, Chinese, Filipino, and Vietnamese. A high proportion of implant reconstruction was seen at a rate of 40.9%. In addition, the study also highlighted disparities in the frequency of bilateral mastectomy. Among patients who had this reconstruction, 85.2% underwent unilateral mastectomy, while 14.7% opted for bilateral mastectomy. Notably, bilateral mastectomy were more common among white patients at a rate of 92.3%, while Black patients accounted for 6.1%, and patients of other ethnicities were represented by 1.5%. Next slide, please. And so, in conclusion, our findings suggest disparities in access to breast reconstruction and variations in the reconstruction types based on race and ethnicity. Autologous reconstruction appeared more prominent among Black patients, while implant reconstruction was the highest among white patients and other racial groups. Moreover, white patients underwent bilateral mastectomy more frequently than Black patients. So, this disparities definitely do raise a concern about and call for further research to dive into the underlying causes of this disparities. We must strive for equitable access for appropriate treatment options for all breast cancer patients, regardless of their race or ethnicity. By acknowledging and addressing these disparities, we can work towards a future where every woman receives equitable care and support in their breast cancer journey. Thank you for your attention, and thank you for the opportunity to present my research at the first Raw Surgery Medical Research Symposium. And thank you to the team at University of Pittsburgh, Department of Plastic Surgery, Dr. Dale Cruz, Dr. Villavalzo, and Dr. Mara.
All right, Nicole, thank you very much for that wonderful presentation. Next up, we have Nicole Nikolov.
Give me just a moment to share my screen. I apologize, my computer's being a little bit slow. Just one more minute, I'm sorry. Okay, can everyone see my screen?
Yes, yes, we can.
Okay, well, hello everyone. My name is Nicole Nikolov. I'm a third-year medical student. This is a project that I did in basic sciences with Dr. Selfridge and Dr. Wright. If some of you remember the cardiac cycle, it was taught by Dr. Wright in basic sciences using his novel teaching aid, the Wright table. He left shortly after my time, so I'm not sure if everyone who's present here today remembers his table to teach the cardiac cycle. However, I'll discuss it a little bit shortly. So I created a supplement to his table to demonstrate atrial septal defect. So a little bit background on the Wright table. Basically, Dr. Wright developed it as a supplement to the Wiggers diagram. The Wiggers diagram, as we all know, is a very thorough and comprehensive model of this cardiac cycle. However, when students are initially exposed to it, it can be very difficult to understand. So as a result, Dr. Wright, in response to the traditional difficulties for students to utilize the Wiggers diagram to understand the cardiac cycle, Dr. Wright developed this table as a novel approach in response to these traditional struggles of students understanding the physiological dynamics of the cardiac cycle. And it acts as a supplement to the original Wiggers diagram as it helps students to visualize the heart working as a pump in a different format using a table rather than diagram. So he published it as a teaching tool for medical education in the Advances Physiology using two normal cardiac cycle tables. However, upon publication, the reviewers recommended the creation of certain tables to show pathologies. So as a response to this, Dr. Wright created some student groups and organized us to develop graph tables explaining various different pathologies. So my group was assigned atrial septal defect in the early phases. So this is the right table for the cardiac cycle of the right heart. Basically, Dr. Wright utilizes a table to show the 4 different cycles of the cardiac cycle and the different locations, showing the flow of blood from one system to the next chambers, as well as showing the electrophysiological changes, the valve openings, and the pressure gradients. He utilizes the same thing to describe the left heart, utilizing different pressures, as the pressures on the left side of the heart are higher. And again, he describes the same cycle using different, so he utilizes arrows. The red dot symbolizes the flow of blood through the different chambers and vessels of the heart. The black lines here are the valves of the heart, and then pressure gradients are demonstrated here in the contracting phase as a dark outline, as for example, the left atrium contracts during the active ventricular filling, the pressure increases, and then the dotted lines demonstrate relaxation of those chambers. So atrial septal defect is a common heart abnormality which accounts for approximately 10 to 15% of congenital heart disease. And it's an abnormal fixed opening in the atrial septum caused by incomplete tissue formation that allows communication of blood between the right and the left atria. This creates a left to right shunt as well as a pressure gradient with blood flowing from the left side of the heart to the right side of the heart. So for this project, we conducted a literature review of the pressure gradients and the flow dynamics that occur in atrial septal defect. And we utilized the right table of the cardiac cycle to demonstrate the pathophysiology of early atrial septal defect in the cardiac cycle. So this is the table that we created. Like I mentioned, in atrial septal defect, there's an opening in the atrial septum in the heart that leads to an abnormal connection between the left and the right atria. So this causes oxygenated blood to flow from the left side of the heart to the right side during atrial contraction. That's why I chose to demonstrate this cardiac pathology using phase 2, the right table, which is active ventricular filling, which is also when the atria are contracting. So the top half of the table is the normal physiology to offer a comparison to what happens during atrial septal defect. And as you can see in the bottom half, oxygenated blood flows from the left atrium through the atrial septal defect right here and mixes with deoxygenated blood in the right atrium, hence creating this purple arrow demonstrating that mixing of blood. So this is also known as a non-cyanotic defect because the semi-oxygenated blood never enters the systemic circulation, but rather goes back to the lungs. As a result of the left to right shunt, the pressure and the volume in the right atrium increase. Normally, you can hear a physiologically split S2 during inspiration because the increase in venous return on the right side of the heart delays the closure of the pulmonic valve. However, in atrial septal defect, you have a constant flow of blood into the right side of the heart, leading to a consistent delay in pulmonic valve closure and the characteristic fixed splitting of S2 that's heard in atrial septal defect. And again, here I'm demonstrating the increased pressures on the right side of the heart compared to the normal pressures on above, and then decreased pressures on the left side of the heart due to blood flow from left to right. So in conclusion, this project reveals the potential utility of the right table to serve as a novel teaching and active learning tool for atrial septal defects, as well as a myriad of other cardiac pathologies. This is just one example of the application of the cardiac cycle, which demonstrates the timing and phase at which cardiac pathology occurs during the cardiac cycle, direction of blood flow, the pressure dynamics that occur during the defect, and correlation with clinical findings such as the heart sounds that are heard, the electrophysiological findings. So it demonstrates that the cardiac cycle can be used in conjunction with, so the right table can be used in conjunction with supplemental tables that illustrate cardiac pathologies, and that can be used as an active learning tool by students to illustrate changes in the cardiac pathophysiology. Dr. Wright has previously, in his original publication, he has surveyed students which show positive impacts in students' learning. So I believe the same thing can be utilized in these cardiac pathology tables, and they can be applied to a wider range of pathologies as well. Thank you all very much.
Very interesting presentation. Thank you so much, Nicole. Next up, we have Kyung Yoon. Kyung, you are muted, so go ahead and unmute yourself so that we can hear you, please.
Oh, sorry. Good morning. My name is Kyung Yoon. I will be presenting a case report on vasovasoral-induced small bowel obstruction without any common predisposing factors. So small bowel obstruction is a surgical emergency. Common risk factors are adhesions from prior abdominal surgery, hernias, and tumors. And vasovasorar are composed of undigested plant material, typically fibers and cellulose, which are a rare but well recognized cause of gastrointestinal obstruction. So this patient is a 43-year-old male without any significant past medical or surgical history, presented with severe left-sided abdominal pain since 10 a.m. And he denied nausea or vomiting. Last bowel movement was 5 hours prior to the presentation. And upon further questioning, patient reported eating a whole coconut the day before. So on the image, and then the patient had no significant past medical history of any GI cancers, no social history, and then he was not taking any medication. And physical exam was like pretty benign. Vital signs were pretty benign. He only was hypertensive, and everything else was within normal limits. And then on examination, abdomen was distended, rigid, and then diffusely tender. And then greatest on the left lower quadrant, left-sided. And then on the laboratory finding, he only had elevated white counts, and then all the electrolytes were within normal limits. And on imaging, it showed that small bowel dilated small bowels, measuring up to 4 centimeters, and then there was a transition point on the left lower quadrant, consistent with small bowel obstruction. So the patient's clinical course, so he was just managed as a small bowel obstruction, kept MTO and then pain management, and then nasal gastric tube was placed with minimal output. And then patient was admitted and then scheduled for emergency exploratory laparoscopy. And then upon going into the surgery, patient had, like right prior to going into the surgery, he was actively vomiting bilious sepsis. And then in the OR, the proximal bowel root was dilated with congestion, and the hard stool bowl was felt. So the laparotomy was converted to open, and then there was the surgeon put a enterotomy to in the jejunum to milk the bowel content, and then the bowel content showed undigested coconut materials. And then the enterotomy closed, and on the post-op day 1, abdominal distension subsided, and the nasal gastric tube was actively putting out about 1 liter of bilious fluid. And then on post-op day 2, patient passed flatus, and then obstructive bowel series showed contrast in the colon. And then full bowel function returned on post-op day 5, and he was advanced to clear liquid diet. And after on post-op day 6, nasogastric tube was removed because it was putting out minimal. and then he tolerated full liquid diet before discharge. So in conclusion, this 43-year-old patient came in with signs and symptoms of small bowel obstruction without any predisposing risk factors, which are adhesions from prior surgery, hernia, and tumor. So small bowel obstruction cannot be ruled out on a patient without any common predisposing factors, and undigested plant material can cause small bowel obstruction. And it is important that clinicians should be aware of these findings so that patients with these symptoms can actively managed, because small bowel obstruction is a surgical emergency. Thank you.
Well, very interesting presentation on phytobezoars. I wasn't aware of those, but now I am. Very, very interesting. Thank you so much, Kyung. Next up, we have Nicole Arriga.
Hi, good morning, everyone. Again, I'm a fourth year. My name is Nicole Orega. I'm a fourth year at Ross, and I'm also a research fellow at University of Pittsburgh Department of Plastic Surgery. So today I'm going to be presenting a research abstract titled Balancing Diversity, Equity, and Inclusion with Professionalism on Social Media in Plastic Surgery. So imagine in a world where social media connects us all, it is essential for us to examine how we can navigate the delicate balance between embracing diversity, equity, and inclusion while also upholding professionalism in the field of plastic surgery. As we all know, social media has become an integral part of our daily lives, including the field of medicine. Plastic surgery, like many other professions, utilizes social media and virtual platforms to communicate with colleagues and patients. However, despite its widespread use, the guidelines of professionalism, particularly in terms of non-discriminatory and inclusive communication, remains unclear. So while diversity, equity, and inclusion efforts are increasingly being incorporated into workplace, little attention has been given to how this translates in the principles of virtual spaces. Therefore, the objective of this project was to evaluate the current social media guidelines within plastic surgery programs and report on the incidents related to unprofessional behavior on social media for the past 13 years. Next slide, please. So to conduct our study, we performed a retrospective cross-sectional literature review. We extracted current social media guidelines from various plastic surgery programs and affiliated departments and universities. Additionally, we obtained incident-related reports involving healthcare workers from the top 10 US news articles published within the last 13 years. We used keywords such as unprofessionalism, fired, and the name of popular social media platforms like TikTok, Facebook, Instagram, and Twitter. Next slide, please. So our results revealed several key findings. So out of the 17 news articles we acquired, 4 were excluded due to limited information or being located from outside the United States. The incidence of unprofessional behavior primarily occurred in urban settings and involved healthcare workers, including residents, nurses, and attending physicians. The most common offense observed was the violation of the HIPAA regulation. In response to this incident, the institutions typically enforced disciplinary actions and employees were dismissed. Furthermore, our study found out that only 11 out of 23 plastic surgery medical nursing societies had specific guidelines for social media posting. Additionally, 4 out of 85 plastic surgery programs affiliated with the medical schools lacked comprehensive guidelines in this regard. As you can see in the data presented below in the figure, it shows the incident reports detailing the locations, the professional titles, incident type, and social media involvement and consequences. Next slide, please. In conclusion, our study highlights a concerning lack of clear guidelines for the appropriate use of social media in professional settings, which may be contributing to the incidence of this unprofessional behavior. Although some guidance exists at the medical school level, it appears to be inadequate post-graduation. So this finding emphasized the urgent need for increased efforts to establish clear and concise guidelines for our social media use within the field of plastic surgery. So our research today serves as a foundation for future studies in this area and also contributes to the ongoing dialogue on the role of social media in professional settings. Moving forward, it is crucial that we work towards developing comprehensive guidelines that address these challenges and balancing diversity, equity, and inclusion with professionalism on social media. Thank you so much for your attention. Thank you for the opportunity to present my research at this first Raw Surgical Medical Research Symposium. And thank you to the team at University of Pittsburgh Department of Plastic Surgery, Dr. Dela Cruz, Dr. Villavaso, and Dr. Mara. Thank you.
Hey, thank you so much, Nicole. That was very, very interesting. And in a world where social media is increasingly becoming a mode of communication, especially for physicians as well, to reach our patients and reach the general public, this is very important. So thank you so much for that wonderful presentation. Next up, we have Miss Chanel Rutledge.
Hello, everyone. My name is Chanel Rutledge. I'm a third-year medical student. Fourth-year medical student. I want to know if you have the poster on yours. Okay. Okay, perfect. Okay, so I did my core rotations at Mount Sinai South Nassau in Long Island, New York, and we did a study on perceived disparities in healthcare and the impact on family consent to disease organ donation. So just some background information. One eligible organ donor can potentially save 8 lives through solid organ donation. And as of July 2022, there are roughly 106,000 candidates in the US waiting for a life-saving organ transplant. And about 75% of these people are waiting for transplants are people of color. But despite this high need of organ donation, the conversion rate from eligible to actual organ donation remains low nationally. And there are several factors that could have influenced this organ donation authorization, including cultural or religious beliefs, knowledge and attitudes regarding disease organ donation transplantation, as well as distrust in the healthcare system. So in this study, we sought to determine whether there were perceived disparities in healthcare delivery, which negatively impacted families to decline authorization for diseased organ donation. So our hypothesis is that perceived disparities in healthcare delivery would lead to lower organ donation consent rates. And for the purpose of this project, we focus on perceived disparities related to religion, ethnicity, or race. And we sought to identify areas of perceived disparity which our hospital may be able to address in the future to improve organ procurement rates. So this was done through a retrospective analysis study. Cases referred to the Institute from the years of 2016 to 2021. All referrals made to the Organ Procurement Organization were reviewed with a thorough look at the reasons why family members provided regarding their final decision for organ donation authorization. So what we found was, out of 416 referrals, 75 eligible donors were identified. Only 22 families, which is 29%, gave authorization for donation, and 53 families declined authorization, 70.7%. 6 patients actually consented, were unable to have timely organ retrieval and successful donor conversion. So as we can see, declined authorization by race, 65% white potential donors, which is 26 out of 40, declined authorization. 17 out of 19 Black individuals, 89.4% declined authorization. 7 out of 12 potential Hispanic donors, which is 58% declined authorization, and 3 out of 4 potential Asian donors, which is 75% declined authorization. So this is like kind of alarming because we're like, they're not necessarily perceiving a disparity, but what is causing them to decline authorization? What are their thoughts that they're just not expressing to the hospital in general, or just like the organ procurement organization? So we kind of sought to see if there were any disparities, and this is what caused us to do this research. So one of 75 eligible donors, families cited a perception of racial disparity as their reason for declining authorization. So I just want to read the blurb of exactly what was said. So There was one documented case of a family's perceived disparity in healthcare delivery based on race, which directly led to family decline authorization. The details of this case were reviewed in detail and further understood to further understand and identify any discrepancies that might have occurred. So this patient's next of kin stated that she witnessed a white male in the room next door have surgery for his head trauma, and her son wasn't offered the chance for surgery. The patient's admission note stated 26-year-old male was brought into the emergency department status post of motor vehicle accident at high speed. The patient's car hit a tree, and he had subsequently suffered a subarachnoid hemorrhage with a GCS of 3 upon arrival. The patient was and remained areflexic under hyperthermia protocol, and neurosurgery was unable to offer any therapeutic intervention, and the patient was declared brain dead 4 days later. So it is possible that the family believed the patient to have suffered the same or similar type of injury as the neighboring Caucasian patient, and that the patient could have been offered the same treatment. Thus, this may have been perceived as a disparity and discrimination based on race. So there was also other reasons why families, the main common reasons why families declined authorization mostly were known reasons, unknown patient wishes, preservation of body integrity, and inferred wishes. And also, one family rescinded authorization without reason, despite their family member being on the state donor registry. So in response to our findings, Mount Sinai South NASA has proactively increased engagement with the Organ Procurement Organization. We are actively filling the gap in the need for organ donation education and residency and fellowship curriculum at our institution. So this study led to the formation of an organ donation education committee, which has integrated organ donation into the end-of-life palliative care curriculum, resulting in increased collaboration with critical care, medical and surgical teams, as well as ensuring that both palliative medicine and spiritual care are offered to all families engaged in organ donation conversions with Live on New York, which is our local organ procurement organization. We have also held special medical grand rounds, which discuss the organ donation process, as well as implemented strategies to improve dialogue and promote education to patients and lectures to the spiritual care team. We are also working to engage our surrounding community through outreach. And it is important to also understand the reasons family consent or refusal for authorization, which may inform future policies and practices involved in improving organ recovery. So some of our strengths in our study were that although this was a retrospective observational study at a small institution, the results facilitated collaboration with other teams and allowed for small group education. So we're allowed to make a lot of change in the hospital as a result of this study. Some limitations, we acknowledge that this is a small sample size and an inability to associate any statistical significance, and we could also possibly expand this to the entire Mount Sinai Health System in New York, and not just the Long Island Hospital that we did. So that brings me into the future initiatives that we have. We would like to spread outreach to the local communities and New York City boroughs to provide education about the organ donation process in general, encourage individuals to get educated about organ donation and tell their loved ones as well. And this may help to mitigate myths and misconceptions between families. And thank you to SMSIG, and thank you to Mount Sinai South NASA for this opportunity to present my research.
Wow, excellent presentation, Chanel. Very informative. Very informative. Next up, we're going to be moving a little bit ahead of schedule because we had a duplicate. So we'll have Miss Nicole Arriga back up for our scheduled 11:50, but we're running ahead of time, which is excellent. This is exactly what we'll be needing when you're presenting at different conferences. So thank you so much, everyone, for being respectful of your allotted time. And again, we have Miss Nicole Arriga.
Sorry, just 1 second. My webcam kind of fell out of place.
And Nicole, we are moving quite ahead of schedule, so take a few moments to gather yourself.
All right, sounds good. My webcam is kind of like dangling and like fell out of place, but we're back.
No worries. We're pretty much 16 minutes ahead of schedule, so.
Okay.
Good.
Perfect. Good morning, everybody. My name is Nicole Orega. I'm a fourth-year medical student at Ross. I'm also a research fellow at University of Pittsburgh Department of Plastic Surgery. So today I would like to present a research abstract titled The Retrospective Analysis of Postoperative Results Using OviTex's Resorbable Matrix and Implant-Based Reconstruction. Imagine a world where breast reconstruction surgery not only effective, but also utilize innovative materials to optimize outcome. So the goal of this presentation is to discuss the use of OviTex PRS matrix and its potential to revolutionize the field of plastic surgery. Next slide, please. So breast reconstruction following mastectomy plays a crucial role in breast cancer management. Biologic matrices has been widely utilized to enhance tissue expander and implants, improving both support and aesthetic outcomes. One commonly used matrix is the human acellular matrix called alloderm, but its high cost and potential for bottoming out has prompted the search for alternative materials. OviTex PRS is a reinforced tissue matrix, also a biological semi-synthetic mesh composed of ovine forced stomach and polyglycolic acid, has shown promise as a viable alternative. The matrix structure incorporates micropores, macropores, fenestration to facilitate better fluid management, tissue integration, and directional flexibility. So our study aimed to evaluate the postoperative complications associated with the use of OviTex PRS and an implant-based breast reconstruction. Next slide, please. So to conduct this research, we performed a retrospective analysis of 22 patients who underwent immediate breast reconstruction with tissue expanders and OviTex PRS at a single institution between 2020 to 2022. We also reviewed the patients' medical records to identify postoperative complications. The patients were also followed for a period of 1 to 3 months after surgery, and the incidence of complications was analyzed in relation to the patient's and surgical factors, such as BMI, mastectomy type, implant volume, and radiation therapy. Next slide, please. So our results revealed that the most common complications observed were skin necrosis at 14%, cellulitis at 8%, and hematoma at 5%. Less prevalent complications included seroma, bottoming out, pocket infection, dehiscence, each occurring at 2.7% of patients. We also found out that mastectomy type and BMI were significant predictors of surgical complications, with modified radical mastectomy and a high BMI also associated with an increased risk. Additionally, perioperative external radiotherapy was also found to be linked to a higher risk of local complications. Notably, we did not observe any cases of capsular contraction in this series. Also, patients also reported a high satisfaction rate of greater than 82/100 based on the breast Q questionnaire. As you can see on the left-hand side of the screen, the first figure on the top shows the mastectomy type as well as the surgical complication, just going over what I just discussed. And then at the bottom side of the screen, we see a 56-year-old patient post-op after the surgery and with the use of OviTex PRS. Next slide, please. In conclusion, OviTex PRS shows a promise as an alternative dermal biological matrix for implant-based breast reconstruction. This matrix has also demonstrated improvements in reconstructive outcomes, while other previous studies out there suggested an increased risk in skin necrosis and cellulitis and immediate breast reconstruction. Our study did not find any specific evidence linking these complications to the use of OviTex PRS. However, it is important to note that our case has its limitations, drawing definitive conclusion regarding this potential discussion. It's also crucial to carefully consider factors such as patient selection, appropriate use of tissue expander, implant volume, postoperative care to also optimize the reconstructive outcomes. Further studies are definitely needed in this field to evaluate the long-term safety and efficacy of OviTex PRS resorbable matrix and breast reconstruction. Thank you for your attention. Thank you for the opportunity to present my research at the first Ross Surgical Medical Research Symposium. Thank you to the team at Larkin Hospital Department of Plastic Surgery, Dr. Castrillon, Dr. Anton, and Dr. Stamato. Thank you.
Well, what a great presentation. Thank you so much, Nicole. Times three. One more coming up. Next up, we have Kayla Martinez.
Hello, hi. I'm gonna present. Can you open it for me? Thank you. If you have it, I think I sent it late. Okay, perfect. Hi, everyone. My name is Kayla Martinez. I'm a fourth-year medical student at Ross. I'm applying for general surgery residency this fall. So I'm presenting this case, a case report that was a pretty interesting case that I saw on my surgery core rotation. So I'm presenting ectopic pancreatic tissue leading to intussusception of the small bowel. So as a small introduction, ectopic pancreas is a relatively rare congenital anomaly that can be seen pretty much anywhere throughout the abdomen, but most notably in the duodenum and ileum. Usually cases of this condition are reported upon autopsy, usually 2 to 5%, but sometimes this condition can present when it becomes symptomatic. So clinical presentation of this disease varies on a case-to-case basis. Some patients complain of GI bleeding or abdominal upset, while others have more kind of concerning presentations such as intussusception or small bowel obstruction. So the patient that we had was a 38-year-old male who presented to our ED for abdominal pain. He stated that at night into early morning, he had severe diffuse abdominal pain with nausea and vomiting. His last bowel movement was at 3 a.m. the day that he presented to our hospital. Prior to seeking treatment, he did try to take Pepcid and some antacids, which alleviated his symptoms only momentarily. And when he fell asleep, he woke up with more intense pain. Prior to coming to our hospital, he did seek medical help at another hospital that was closer to his house. There he received IV morphine, Toradol, and a GI cocktail, which again helped his pain, but only momentarily. So he was transferred to our hospital for surgical intervention. Some past medical history on our patient. In 2019, he reported that he was diagnosed with H. pylori. That was done via breath test, and he was treated to eradication, but he never received a colonoscopy or EGD, which is greatly unfortunate. He has no significant past medical history or surgical history, and he just takes antacids here and there. His family history is prominent for colon cancer in his paternal uncle and colon polyps in both of his parents, but they are of advanced age. He denies any illicit drugs, alcohol, previous or current tobacco use, and he reports a balanced diet, and he was a pretty fit male. So on physical exam, his bowel sounds were present throughout. His abdomen was soft and non-distended. There was some tenderness noted to the epigastrium and periumbilical region, but there was no rebound tenderness or guarding or rigidity. His vital signs were unremarkable for the most part. Systolically, his blood pressure was 140, and he was afebrile at 98.5 degrees Fahrenheit. The table on this poster does demonstrate some of the mildly abnormal labs that he had, but for the most part, he was relatively stable other than his symptoms that he had. So he had a white blood cell count of 12.5, a lipase of 8, and a billy of total billy of 1.7. And that was pretty much it for his CBC, CMP, and electrolyte panels. So while he was at our facility, of course, we had a repeat imaging. He had a CT of the abdomen and pelvis with PO contrast, which showed a 2 by 3.3 centimeter intraluminal lipoma with an extremely long, fatty, thin stalk in the distal small bowel. This was causing obstruction with upstream dilation and moderate distension of proximal loops of bowel. The appendix also on imaging looked fluid-filled and dilated, and it was believed that initially that this was likely reactive from the obstruction. On imaging as well, mesenteric lymphadenopathy was also noted, so it was that significant. So giving the concerning presentation from his imaging, surgical intervention was strongly recommended, and that's exactly what we did. So figure 1 and 2 kind of show the mass and the intussusception that is relevant to him. So figure 1 and 2 kind of show that in different views. We wanted to break up the pre-op, intra-op, and post-op diagnosis because they kind of do change throughout the procedure. So initially, his pre-op diagnosis was small bowel intussusception, likely ileocecal in origin, which is the most common form, secondary to a mass. However, once he finally received his XLAP, he did have a small bowel intussusception, and a small bowel resection was performed with primary anastomoses. So 2 areas of full thickness ischemia were found within the bowel, and this is believed to be a result from the intussusception. So a primary anastomosis was made there. Approximately 10 centimeters to the mass of the small bowel and nearly a foot from the ileocecal valve was transected as well. And that the lipoma and the transection of those parts of the bowel can be seen in figure 3. Large lymph nodes in the mesenteric small bowel were found in this region. Those were also transected and believed to be linked to his intussusception. And the appendix appeared distended with a mass that appreciated in the middle of the appendix, and an appendectomy was performed. This mass specifically was sent for a pathological examination, which showed ectopic pancreatic tissue surrounded by an adipose tissue. So his post-op diagnosis was changed to intussusception of the small bowel secondary to a mass with appendectomy. So subcutaneous sutures were placed and the abdomen was approximated with staples. He had no complaints and tolerated the surgery very well. So this case has rarity in the fact that it's intussusception in an adult, and it also has an identifiable pathological lead point. Some risk factors for intussusception in adults include Meckel's diverticulum, cysts and polyps, lipoma, and PJ syndrome. So the pathophysiology of intussusception is linked to a pathological lead point in the intestines, causing a segment to intussuscept or telescope on the adjacent portion of the bowel. Our patient did not have a history of any prior GI congenital anomalies or malformations. However, he did find a mass on CT. It could be argued that in 2019, if he did receive a scope, this could be identified earlier. So ectopic pancreas, also called heterotopic pancreas, is believed to be a congenital disorder described as pancreatic tissue found outside the expected pancreatic frame. This abnormality is thought to be a result from the separation of pancreatic tissue components during the process of rotation of the foregut, followed by fusion of the pancreatic buds. There's 2 widely accepted or most commonly accepted theories as to why ectotopic pancreas happens. First theory explains the fetal migration of pancreatic cells occurs outside the pancreatic frame, which is kind of just bluntly stated. And the second theory is abnormally located immature gastric mucosa inside the submucosa of the abdomen that later becomes pancreatic metaplasia. Literature review stated that ectopic pancreas can present in any stage of life, however, most commonly in the 5th and 6th decades. So intussusception for adults is treated with a resection or XLAP to identify the pathological lead point, or if they have a mass that's causing tissue necrosis, it definitely needs surgical intervention. However, for children, this condition is treated mainly with, or initially with, non-operative reductions such as water-soluble contrast enema or an air enema. So in conclusion, we wanted to present this case due to its rarity. We wanted to shed light on the coexistence of intussusception and the coexistence of ectopic pancreas that can lead to this. We wanted to discuss this presentation to assist in care and management of future patients with similar symptoms. And that's it. Thank you.
Hey, great job, Kayla. Thank you so much for that informative presentation. Next up, we have Nicole Errega.
Hi, good afternoon, everyone. So my name is Nicole, like I said 3 times already. I'm a 4th-year medical student. I'm also a research fellow at UPIT. So today I'm going to be presenting you on the topic of the abstract titled Gender-Affirming Surgery and its Complication, with a special focus on racial disparities. In the rapidly evolving landscape of gender-affirming surgeries, where acceptance and access has grown, it is imperative that we turn our attention to the comprehensive understanding of its outcomes. So today, I invite you to explore this research abstract that uncovers the impact of race and ethnicity on post-operative complications following gender-affirming bottom surgery. Next slide. So over the past decade, there's been a significant increase in the incidence of gender-affirming surgery, driven by its greater social acceptance and improved healthcare coverage. However, there remains a gap in literature when it comes to understanding the outcome profiles following these procedures. While some research has been conducted in this area, only a fraction of it has considered the influence of race and ethnicity, and even fewer studies have explored outcome disparities beyond just the comparison of Black and white individuals. Our study goal today is to address this gap by examining racial disparities and complication following gender affirming bottom surgery, with a specific focus on Hispanic ethnicity as its own distinct category of comparison amongst other racial groups. Next slide, please. So to conduct this research, we analyzed patient data from the NIH database spanning from the years 2012 to 2019. Patients with clearly defined racial information were included in the study. We then selected patients who had undergone gender-affirming bottom surgery based on specific ICD-10 procedure codes related to genital reconstruction. Using the ICD-10 CM codes and chi-square analysis, we compared the rates of post-procedural complication amongst different racial groups. Our analysis aimed to identify any association between race and post-surgical complication. It is also important to note that possible confounding variables such as socioeconomic status, insurance status, age, and pre-existing conditions were considered during our analysis. Now let's move into the results of our study. Next slide, please. So this table here right in front of us is showing the post-procedural complication incidence and chi-square analysis amongst infection, wound diseases, GU bleed, stenosis, fistula, and adhesion. Interestingly, our analysis did not reveal any evidence to suggest a significant association between race and post-surgical complication, with a p-value in those categories, as you can see on the right-hand side, being greater than our set alpha of 0.05. However, it is important to acknowledge the presence of potential confounding variables that might have influenced these results, such as, like I mentioned earlier, the socioeconomic status, insurance status, age, and pre-existing conditions. We also recognize that some patients in our analysis may have undergone the procedures of interest unrelated to gender affirmation surgery, and their inclusion might have skewed the results that we currently have. Also, some patients underwent gender affirming bottom procedures may have inappropriately been excluded if their procedure was not assigned to specific ICD-10 code procedures used in our screening process. As with any studies, there are always limitations, and this include a very relatively small sample size, the disproportionate representation of certain racial groups, and the use of secondary data points from the NIH database. This limitation should definitely be taken into account when interpreting our findings. Next slide, please. In conclusion, our study sheds light on the issue of racial disparities and complications following gender-affirming bottom surgery. While we did not find any significant association between race and post-surgical complications, it is, however, important to acknowledge the influence of confounding variables and the limitations of our study. Further research with larger sample size and more diverse racial representation is needed to gain a comprehensive understanding of this topic. Thank you so much for your attention. Thank you for the opportunity to present my research at the first RUS Medical Research Symposium. And thank you to my fellow colleagues at Rogers School of Medicine for the collaboration on this project. Thank you.
Thank you, Nicole, for another wonderful presentation. Last up for the day, we have Esther Kumetz. Unfortunately, she couldn't make it to our meeting. However, she did pre-record a presentation for us, so I'm looking forward to hearing it.
Can you guys let me know if you're not able to hear it once I share?
But we can't hear it.
Yeah, we can't hear it. At least
Thank you.
know when she starts talking, but yeah.
Okay. Let me see. Can you guys hear it this way?
Nothing yet. No.
How about now?
Good afternoon, everybody, and
Yes.
thank you for being here. The topic of my research is applications of photodynamic therapy in wound and burn healing, which is a literature review. So a little bit on the introduction. Burns are a global public health issue because wound infections are a common complication that delay or prevent healing. Therefore, reductions in overall wound infection rates will be beneficial to patient outcomes and reduce overall costs. Inevitably, all wounds will be colonized by some bacteria. However, Staph aureus bacteria accounts for the majority of wound infections, and outbreaks of various multi-drug resistant bacterial strains unfortunately happen at an alarming rate. So therefore, physicians and patients are in a greater need of alternative treatment options. The purpose of this review is to assess an alternative treatment, such as photodynamic therapy or PDT, for the treatment of burn and wound infections. And PDT, or photodynamic therapy, uses light, a photosensitizer, and a molecular oxygen to form an excited state of oxygen, which is known as a singlet oxygen, to cause cell death and kill microbial cells. PDT offers multiple advantages over antibiotics and UV therapy. In particular, it offers broad antibacterial activity, rapid action, and localized treatment. Additionally, it offers a lower risk of systemic side effects and leads to effective inactivation of bacteria regardless of drug resistance. However, there are some challenges pertaining to the use of PDT, such as imperfect selectivity for bacteria over proteins and cells in our bodies. So the objective is to investigate the applications of PDT on the healing of wounds and burns and assess current study limitations in vivo and in vitro and suggested theories. I will also evaluate the side effects and potential for clinical studies and compare the use of PDT to an alternative treatment such as antibiotic use. The following were the search items, electronic database search, and the inclusion criteria. Before I proceed to discuss the results, I wanted to point out that the energy from the photosensitizer can either be transferred to form radicals, which is a type 1 reaction, or to form singlet oxygen, which is a type 2. So in this study, we're focusing on type 2 mechanisms. As you can see in figure C, it shows that the photodynamic therapy group exhibits an accelerating healing of excisional wounds infected with the A. baumannii by destroying bacteria. And you can easily pinpoint that the advantage becomes much more measurable after 7 days. And when we take a look at figure D, we see that the pro-inflammatory cytokine IL-6 levels in infected mice treated combined with the light dose of 50 joules per centimeter squared have decreased, and the growth factor increased significantly. So the PDT-mediated reduction of bacteria in the burn wound is rapid, which is less than 1 hour, in comparison to a standard therapy such as silver sulfadiazine cream, which does take several days to work. And you can observe the figure D for yourself, which clearly represents the IL-6 levels, the basic fibroblast growth factor. So when we look at figure E, we're comparing light dose versus bacterial growth. And these figures show that the Staph aureus bacteria are inactivated by photodynamic therapy. And Staph aureus and multi-drug resistant Staph aureus are also inactivated by photodynamic therapy in a light dose dependent manner. When we look at the wound healing versus the photosensitizer concentration in different days, we clearly see a difference. As I said previously, photosensitizer is something that is used to excite the singlet oxygen to form. So this figure F, demonstrates that topical treatment with the photodynamic therapy significantly accelerated wound healing in mice compared to the control group. And you could see that it starts from day 1 to day 7. And if you look to the far right, it starts with a concentration of 2 micromole going to 10. And you can clearly see for yourself that the wound healing is essentially much more accelerated the more we increase the concentration of a photosensitizer. To continue, unfortunately, we have found that elimination alone can exert a damaging effect, and reduction of the light dose could therefore be beneficial to the wound healing process. It has been studied that the major side effects could include residual photosensitivity to the accumulation of a photosensitizer. So when exposed to sunlight, it can be characterized by burning, redness, and swelling until the drug leaves the system. So it is strictly advised to avoid sunlight exposure. And some other side effects have been noted, such as temporary coughing, stomach pain, pain in the site treated, and trouble swallowing. Since the photosensitizer is applied topically or locally onto the affected area, systemic absorption is thought to be minimal. And we still question if bacteria can develop resistance to photodynamic therapy, and it has been studied that gram-negative bacteria can control the uptake of a photosensitizer using their outer membrane. So that is primarily the reason why positively charged photosensitizers will only be effective in this case. In conclusion, we can say that a photodynamic therapy offers a broad antibacterial activity, localized treatment, and a lower risk of systemic side effects. Various factors will need to be discussed and investigated before PDT can be safely used as a treatment regimen. As a part of our future studies, we attempt to include an investigation on efflux pump mechanism and inhibitors, additionally PDT selectivity, and evaluate potential side effects. And we also look to optimize photodynamic therapy pharmacokinetics. Thank you, everybody. And if you have any further questions, please feel free to email me at esther.kumets@gmail.com. I will be looking forward to your questions. Thank you.
Excellent presentation. We want to thank Esther for putting together that wonderful presentation on photodynamic therapy. Like I said, unfortunately, she couldn't make it today, but if you have any questions, please feel free to relay those to her email for further information. Now we're going to transition into the next part of our research symposium, which is the question, answer, and comments part. So we'll go by presenter. If we have any questions, please feel free to stop me and we can discuss that a little further. We do have a hard stop time of 2 p.m. Eastern time, so we have about 2 hours for our question and answer session. If we've exhausted all the questions, comments, etc., then we can end at an earlier time. So without further ado, let's start with Ms. Nicole Errega. Do we have any questions for Ms. Nicole Errega today?
So when there is a silence, so I can start, Marek Rudnicki. I would start, however, with congratulating Jamal, Zahir, and Rachel Haranchar for putting together that symposium. Jamal, you are doing great job. You know that I observe you for a long period of time, and congratulations. You are raising activities of our surgery interest group to completely higher level, and leadership of Rachel is visible. And I would like Rachel to stay in that position for a longer period of time. Unfortunately, bylaws do not allow that. Now, a few comments regarding first presentation. I was absolutely surprised seeing such a huge difference between access to reconstructive, not access, reconstructive surgeries done for white and non-white patients. This is important paper, and I think that can kind of make a lot of noise in surgical and not only surgical community. I work on breast cancer ethnic issues for several years, and I'm again surprised seeing such a huge difference between 90 versus 9%, I believe I remember. Seems to me that that paper I would consider as first step for another multiple research projects. First of all, look at those findings from different end, because Nicole, I believe Nicole, presented out a kind of number of surgeries done. But what's the reason for them? If it is possible to look into patients why they did not have that surgery. Maybe some patient didn't want, maybe there is a problem in Black community that women don't want to have reconstructive surgery. I don't remember any papers addressing that issues, because maybe this objective data that Nicole presented might be kind of developed into larger sponsored and funded projects by different companies like Common Foundation or something. So that opens a gate for further work. Thank you very much, and beautiful, beautiful paper. A question, where it is going to be submitted, to which meeting?
Thank you so much for that. We're looking at the plastic surgery meeting, but I'm also going to be presenting it at the Society of Black Association conference, and then the Northeastern Plastic Surgery conference this coming September.
Yes, don't forget about Common Foundation, that you can get funding for that study.
I will. Thank you so much for that comment. And like, you definitely shed some light onto the factors that could possibly be influencing the choices of why there are like more white patients getting this reconstructive surgery. From what I've found from data, insurance status is a factor that can be contributing to this axis of and this disparities amongst patients. Patient education and patient awareness about the options that they have, especially in the Black community. Most patients are not aware about the options that they have when it comes to breast reconstructive treatment, as well as physician bias too. I found that from several studies that have shown physician bias definitely plays a huge role in the access of breast reconstructive treatments to patients. Personally, and a personal goal of mine, when I encounter such patients coming to the breast surgery clinic or to the plastic surgery clinic, I try to make sure they're aware. I'm like, okay, you can get reconstructive surgery. There are options out there for you to get once you get a mastectomy. Just making them aware of the options that they have, and like just addressing any stigma and any bias they have behind those options and those notions. Thank you for sharing that, though. I really do appreciate it.
Hi, this is Bernetta Heron. I wanted to know, did you address, was this for interval reconstruction or for immediate reconstruction?
It was for immediate breast reconstruction.
Okay, and so was there a hypothesis as to why there were different rates of autologous versus implants?
So there has been trend that has shown that breast reconstruction type has shifted towards implant-based reconstruction type because the change in CPT code. So previously there was a CPT code that coded for different types of autologous-based reconstruction, as the deep, the tram, and like the different flaps. But now that has changed, and there's only been one CPT code that addresses all of the types of autologous reconstructions. So most plastic surgeons are shifting towards implant-based reconstruction type to be able to compensate for that, because they do also have a reduced reimbursement rate when they do this autologous reconstruction-based processes. However, that change is not being reflected in our Black patients, but you can see the change amongst the white patients and other patients of different ethnicities. So we're still trying to explore the causes and the line factors as to why this cases and these reasons are happening.
I would echo what Dr. Rudnicki said. I do think it's important, actually, on your first presentation to at least hypothesize or outline some of the things that you've actually stated about potential reasons, because it seemed more like it was just providing data and it was just dropped there. And so there are, I think, important things that need to be addressed maybe in an additional slide, but which will lead to certainly other modes of investigation. And people are doing some of this research out there that I think this will be an important supplement to.
Thank you so much for that.
If I may, additional comment, that natural development of research, that you have facts and you provided factual data. And then you have to look into reasons why something happens. So you can hypothesize, let's say that the reason is that white female are living in appropriate suburbs and they have good access to healthcare, or something else, whether they are more informed by social media, by everything. So those hypotheses can drive that project to completely higher level. So absolutely, it is just beginning of work on that in that direction.
Thank you so much for that.
I had a question for Nicole about your presentation on social media guidelines in plastic surgery. So I'm sure a lot of us here have seen a recent plastic surgeon that was had her license revoked because she was dancing in the operating room. What sort of guidelines did you and your team kind of develop to prevent things like that from happening? It seemed that most of the issues regarded HIPAA violations. What did you and your team kind of hypothesize what would not only inform the surgeons, but also develop like kind of formal guidelines for using social media in plastic surgery?
Thank you for that question. So we hypothesize definitely setting standard and setting guidelines for each institution. So like whatever hospital a physician might be working in, and then their specific department having a specific set of guidelines that talks about social media settings and how to use social media in that regards should definitely be set in place. As we can see from the data we showed, most institutions, most overlying body institutions, they do have some guidelines, but they don't have any specific social media guidelines against such posting. But we know we have an overarching database of like HIPAA guidelines and other guidelines that are followed, but I feel like there's no specific social media guidelines. So we're definitely bringing awareness to this cause and seeing how we can move from there and possibilities of things that we can do and what specific guidelines we can put in place to help decrease this incidence. I know the ASPS has put out some specific guidelines, which is the American Association of Plastic Surgery, which is like the big governing board of plastic surgeons, that put out some specific guidelines, but none is specifically talking about social media guidelines. So we're definitely bringing awareness to this and seeing how we can go from there.
And just a follow-up question to that, what do you think are the implications for a so-called surgical black box? And I'll elaborate on that by saying, in certain institutions they have a surgical black box similar to the aerospace industry, where they have a black box in an airplane. So this process basically records all of the surgeon's procedures and allows their preceptors and attendings to kind of make comments and rate their performance in terms of, you know, how they did a certain anastomosis or how they did a certain excision, et cetera, et cetera. What do you think are the implications if something like that is used to standardize social media guidelines in terms of a black box used in the surgical theater? Like, what do you think could be the potential implications in terms of positives of using that type of technology to rate the performance and behavior of surgeons, but also on the other side, what are the downsides of that if there's a medical legal issue and a lawyer's like, hey, we have a subpoena for the videos, and something that wasn't supposed to be seen is seen. Like, what do you think? What are your thoughts on that?
Thank you for sharing that. That definitely seems quite insightful. I've never actually heard about the surgical black box, but that definitely looks like something worth looking into, and further research needs to be looked at into. So I'll definitely look back into what you mentioned and go from there and give you an answer at a later time. Thank you.
Again, Jamal, you are raising one moment. Can you hear me?
Yes, sir. We can hear you.
You are raising very important issues. How much and how current media can be used to kind of to show surgery outside the operating room. From my perspective, operating room is sanctuary. Is more even than church or mosque or any temple. What you can do in different places should not be done in the operating room. I'm not against taking pictures in operating room, but pictures from OR should be kind of noble. It cannot be like, strange figures, jokes, and so on, because human body is saint. You cannot portray that in strange manner. It's too serious to talk about that. And now you just touch issue of legal problems. I remember when laparoscopic surgery was introduced into surgical armamentarium, there were surgeons who were making videos, and probably there are still some of them making videos and giving videos from surgery to the patient. And there was discussion at one of the sessions at the American College of Surgeons in mid-90s. Should we do that, or should we avoid situations like that one? One case lost by a surgeon that is showing some stupid steps showed that that should not be done, because you are giving outside of the operating room all details that sometimes we can suffer from showing those details. So decision and general perception was at that time that we should not use videos to promote our skills, because sometimes in surgery, just wait. You are great today, great tomorrow, but 5 days later you have problems. So don't forget about that. And once again, from my perspective, making stupid pictures in OR should not be in your plans. Thank you.
Thank you for that, Dr. Nikki. And Nicole actually had to head out. She had a prior commitment here at around 12:15. So she did head out. So if you have any more questions for her, you can reach out to me and I can provide you her email address for any further questions. Next up, we have questions for Kyung, if she's still in the room. I don't think she is. Yeah, I don't see Kyung. Okay.
Yeah, I had to step out as well.
Okay, not a problem. Next up, we have any questions for Nicole Nikolov? I guess I can ask a quick question for Nicole. I really thought the right diagram was very interesting and informative. I would have to look at it a little bit more just to orient myself. However, were any of the other institutions or universities other than Ross, were they privy to this information in this diagram? Do you know? You are muted, Nicole, so we can't hear you.
There we go. Sorry, my computer's very delayed. I was having trouble unmuting myself. I believe Dr. Wright did introduce his original table into a couple of universities inside the United States, and then transferred it over and used it actually to teach us at Ross University. And currently he's working on expanding it to involve different pathologies. So have those supplemental aids in teaching as well.
Awesome, thank you.
Nicole, I have a question for you. Were you assigned ASD or did you pick ASD? And if you were picked it, why did you choose to do this type of pathology?
Thank you. Yeah, we were actually assigned pathologies. There were several groups. He assigned different pathologies. So this was actually part of a larger project in which he's using working with students to create all of these different tables. He actually had several groups create several groups create different tables for the same pathology to see the different variations in what students came up with, to see which one is going to be more applicable to teaching aids, which one's more helpful, and which one was rated as high as for him to include in the largest study.
Any more questions for Nicole? Going once, going twice. All right, we'll move on to Miss Chanel Rutledge. Any questions for Miss Chanel Rutledge?
Yes. Jamal, can you, yes. What title of her talk?
She had the discussion on racial disparities in organ procurement. I guess I can start us off. I had a question. So, what sorts of recommendations or what sorts of recommendations did you have in terms of increasing the rate of organ procurement and authorization from different racial and ethnic groups? Is it a lack of education? Is it a lack of trust? What did your team kind of come up with? And the reason that I'm asking that specifically is because there's a great book by Harriet Washington called Medical Apartheid. And in that book, there's a really extensive discussion on why there's a lack of trust in the medical system, specifically talking about the Black community. And a lot of us may know of the Tuskegee syphilis experiments. That's like the stereotypical example everyone uses, but there's a long history of experimentation on not only our Black constituency, but also prisoners. And an example of something besides the Tuskegee syphilis experiments that everyone knows is the correction of vesicovaginal fistulas. Actually, the correction of vesicovaginal fistulas were perfected on Black slaves, and then which was done all without anesthesia or any regard for human life, and they were perfected until they could be used on the white populace. So what did you and your team kind of discuss is the way to increase that authorization rate? What are your recommendations? What are your thoughts?
Yes, thank you for that. That's a very good question. I actually forgot to include the Tuskegee study and all the history of the mistrust in the community. So basically, we figured that more education and for families would mitigate these myths. Basically, with the education community, we have the residency and the fellowship, where we're hosting rounds probably 3 times a year for them to better educate the families in ICU or just in general of the organ procurement process. And it doesn't mean that just because they're an organ donor that we're just going to stop care, or we're just not going to do the best that we can to save their life. So I think that's another reason why a lot of families decline, because they think that like all care is just going to stop because they're going to try to like hurry up and go to the OR and save these organs. So that's definitely like a big turn that we're trying to like do for research, further studies with the Live on New York Organ Procurement Organization. And yeah, exactly that. Because I know like from my own experience, like growing up in New York, like people always tell you like don't list yourself as an organ donor on your license, like just because people feel like they're gonna get kidnapped and like their organs are gonna get like taken. So like that's just like an example in the community like of what people think of organ donation. They just like it's just like don't trust it. So yeah, that was a really good question.
And just to go ahead, Dr. Hen. I don't want to interrupt.
Oh no, please finish your thought.
Just building on that, do you think that the education needs to be in a like in a formal format, or do you think that it would be more effective to be in an informal sort of education where the information is coming from someone who looks like the patient? I know I'm here in Florida, and I know there's a huge quote unquote penicillin allergy in the Cuban community here. And the reason being, I think early 1900s, there was a large shipment of penicillin, Soviet penicillin, to Cuba. And there was something wrong, some contamination, something wrong where a lot of patients actually died from using that penicillin. So now a lot of our patients here in Florida, specifically the Cuban constituency and Cuban diaspora, they say that they have a penicillin allergy, but it's not necessarily an allergy. So to prevent those sorts of things from happening, do you think that the information needs to come from someone who is a Cuban, or do you think that it doesn't really matter where the conversation education comes from?
I think it's both. I feel like there should be like a formal education just in general for patients, especially like patients that are like families that like the patients in the ICU for a while. Maybe that could be like a formal education there. Also, I feel like just like I said, like in the communities, like we need to just discuss it together, like because that would be like the informal way where they could like, oh, this is not as bad as it seems. Like I'm actually helping people. Like there's a lot of people who want kidney transplant lists. Like there's a huge list of patients that need donors. So I feel like both would be like the best way to go. So like just like starting with ourselves, like talk to our friends and families, and that could spread to somebody else. Like, oh, did you know that like it could spread on just like having one simple conversation with someone.
Okay, so what I'm hearing is like a multivariate, multi-pronged approach, just to cover all your base, like a holistic educational process.
Yeah, exactly.
Okay. Awesome, thank you so much. And sorry to interrupt, Dr. Heron. Go ahead.
Can you hear me?
Yeah.
Yes, we can hear you.
Find that the timing of the conversation, these are difficult times when people have traumatic events or end of life decisions. Did you factor in the timing of when the conversation happened? Also, I would just agree with a lot of what you and others have said. There's a lot of fear and distrust in a lot of communities. And although there's a lot being said about physician-patient concordance in terms of race, ethnicity, language, that kind of thing, improving outcomes, I do think just education, health literacy, and respect for cultural mores and some of the reasons behind some of this distrust and fear throughout and across all providers is important, because we're not going to always be able to control who has these conversations with the patients given the timing and who's within these specialties and that kind of thing. So it's nice to see you all researching this. My second question is like, what would be the next steps in terms of your research and some of your thoughts of some of your findings?
Yeah, thank you for that. So I'm actually glad that you brought up the timing aspect of it, because that was another big limitation. And that's going to be like a future studies for not necessarily like me being involved, but the organ procurement organization could use this for like quality improvement themselves, because like there were so many potential donors that didn't meet time constraints. So like everything just happened too fast. There was like not enough time to even have the conversation with the family. So I also feel like that plays a big factor in just like, you know, it's hard times. Like they're not trying to sit down and talk to the organ procurement like company, I mean organization about this. So it's like, yeah, that yeah. So basically, to answer your question, they're going to look into that further to figure out how to go about this, like to like not like to have longer timing, or I'm not too sure exactly what they're going to do, but that's one future study for sure for like the timing aspect of it, and also like just in general like communicating with families better and the time, the small window that we have for them to consent for organ donation as well.
Thank you.
Thank you.
Any other questions for Ms. Chanel Rutledge? Going once, going twice.
Yeah, I have a quick question, if I may ask. So I see that there was an end-of-life palliative care curriculum implemented after this study. Do you know how the results of that are doing? Like, they finding it successful as at least having more honest and like open communication and conversations versus like more families wanting, you know, their patients to be, or you know, family members to be organ donors?
Yeah, definitely. Thank you for that question. So I don't know exactly for the how it's been going. I just know that they've been hosting like a lot of like grand rounds, just like it's just incorporated in the curriculum for all the residency programs at the hospital. But I actually left after, so I'm not too sure like how their conversations are going with the families like currently. But I know like there's like flyers, and then like there's like the Live on New York procurement organization has like mouse pads. There's like for your ID badge, like on the back of it, like the number to call to get more information. Because like a lot of residents and even like some physicians don't even know like the process of like calling the procurement organization. So that has helped increase efforts a lot. But I'm not too sure exactly how it has affected, like translated into speaking with families. But that's a good question for me to look into.
Thank you.
Do we have any final questions for Ms. Chanel Rutledge? Again, going once, going twice. And we'll move on to Ms. Kayla Martinez. Any questions for Ms. Kayla Martinez?
Kayla, retrospectively, were you able to identify any potential symptoms that the patient was having related to the ectopic pancreatic tissue?
Other than his pain and his nausea and vomiting, and we couldn't really identify like why suddenly it happened. Like he didn't have like an acute illness that could have led to like enlarging of the lymph nodes or anything like that. Nothing really. It just like happened out of the blue. I also forgot to mention that another rarity of this case is that he didn't have an ostomy and the tissue was benign. It was not malignant. So that was like another important fact that the attending that I was writing it for was really like astounded about. It was remarkable to him, I guess.
So I may have missed it if you said this. Was the patient able to have a surveillance of the small bowel at some point, like a pill endoscopy or something?
I think they did. Obviously, now he will have like GI follow-up probably forever, right? But before he was, in 2019, he was diagnosed with H. pylori, but they just gave him like did a breath test, and he didn't get a colonoscopy or an EGD at the time. So like looking back, he could have had this like, I guess like taken out like prophylactically, but he never received imaging, and unfortunately, it had to come to him having a small bowel obstruction and intussusception for him to get it out. Yeah.
So that ectopic pancreatic tissue in the appendix was acting almost like a appendicolith. Although he didn't have frank appendicitis, he could have one day.
Yes, yeah, that's what we were saying. Like it wasn't like that the fecal lift was there. It was like just the mass expanding and I guess being reactive. It was very interesting, apparently. Yeah. So, and he like walked away with like no ostomy, nothing. It was very rare.
Interesting.
Yeah.
Going off of what Dr. Heron said, you already mentioned this, but I'll still ask again. The patient didn't have any endocrine abnormalities, did they? Like because of the ectopic pancreatic tissue?
Sorry, my neighbor is literally cutting grass outside my window. He picked the perfect time, but no, he had pretty much nothing. His white blood cell count was only 12.5. He was resting comfortably after they like had given him medications, especially when he was transferred to our facility initially, and then after giving him like pain medications, he was like in mild distress, mild pain. And then when they had opened him up, it was like very not what they were expecting. That's why I kind of included like the pre-op, intra-op, and post-op, because it changed like with every document and every note that the surgeon had made. So no, he had nothing prior, and his labs were pretty benign for the most part.
Okay. All right. Thank you.
Thank you.
Any other questions for Ms. Kayla Martinez? Going once, going twice, and that actually completes all the question and answer session. Esther Kumets was actually next, however. Any questions that you do have can be related to her email, which we'll put in the chat here shortly. But thank you so much for joining us. Any other comments, questions, concerns about today's research symposium? And I'll close off here soon after any final comments from the attendees. Go ahead, Dr. Dickey.
I'm not sure whether we discussed that presentation on phytobezar. Did we?
No, we did not discuss
Young
that.
had to step out.
Okay, because I would like to start with title, phytobezar without common predisposing factors. Coconut is common or uncommon?
I feel like the coconut is common.
Yeah, because that was coconut is common predisposing factor. And among other lines, I saw that she mentioned that coconut, the reason for obstruction was milked forward. I'm not sure whether that was correct statement, because many surgeons would consider that forward milking is either impossible or not advisable. So maybe that was kind of a little bit miscommunication. Don't you think, Dr. Heron?
Yes.
Yeah.
But yeah, that's something we could probably address with her just to make sure, because I do think it's contraindicated with Bezwars to milk them forward. That's not the standard of care.
Yeah, because
remember,
remember that whatever is causing intraluminal bowel obstruction, whether it's gallstone or Bezwar, it should be milked backwards, because you cannot that blocking structure cannot be pushed forward, because it blocked in lumen at the end of opportunity to moving forward. So it has to be moved backwards and removed from the lumen, and then obstruction is removed and wall is being closed. So generally, and Bezwars are causing approximately like 0.4 to 0.5 to 4% of all small bowel obstructions. So it is kind of is happening. I remember removing Bezwar from orange, coconut. So multiple factors can lead to obstruction. Is Bezwar? It's not only from hair or whatever can come in the stomach and later move down. Multiple factors can lead to Bezwar formation. Thank you very much.
I just wanted to say that I enjoyed everyone's presentation, and it's really great work everyone's doing, and very progressive and well done and professional as has this forum been. And I really appreciate everything you all are doing to help advance everyone's interest in surgery and just their progress and knowledge base, and for us as well, because I learned a lot today. So I appreciate it, and good job, everybody.
Thank you so much, Dr. Heron, for those kind words, and thank you, Dr. Rudnicki, for the input as well. I want to thank all of our attendees. I want to thank the presenters. I want to thank our moderators and our leadership, Dr. Rudnicki, our section chief, as well as Rachel, our executive president. Thank you so much for joining us. Just the last few words before we end our meeting today. So this, the reason that we had this research symposium, one, is to improve not only the quality of our research, but increase the amount of research that we are currently involved in. As we all know, as time goes on, matching into any surgical specialty requires an increasing amount of not only your personal achievements, your academic achievements, but also is increasingly, research is increasingly required as part of matching into any surgical specialty. For that reason, our executive team discussed holding a research symposium. And the other reason for holding the research symposium was so that we can practice presenting in front of a group of individuals in a low pressure setting, so that we're used to not only talking about our research, but responding to questions and comments about our research in a professional setting. And you know, this has been a great opportunity for all of us to present our research in preparation for the upcoming American College of Surgeons conference. Go ahead, Dr. Rudnicki.
Oh, please continue, and after you are done, I can make some comments.
Yes, sir. So this was in preparation for the American College of Surgeons conference upcoming this October 21st to the 25th, I believe. Our first cohort of SMSIG members went in October of 2022 to San Diego, the ACS Clinical Congress. It was a great opportunity to not only interact with our other colleagues from different institutions, but also from our Ross colleagues. I know Dr. Rudnicki was there, as well as a lot of our other Ross alumni. So we want to increase our presence at these different conferences, and not only in person, but in terms of the research and presentations that we have. Deadlines for submitting e-poster presentations for ACS are this July 7th, I believe at 11:59 Central Time. If you have any questions regarding the submission process, what types of studies are accepted, please feel free to reach out to me or Rachel. We'll be more than happy to help you with the process. We have a good relationship established with the medical research coordinator there. So again, please reach out to me if you have any questions regarding that.
It continued the same venue regarding American College of Surgeons. I'm trying to secure funds for our reception, and at this moment I cannot confirm, as it is known to many of you that usually school gives us last moment information that they assign the appropriate funds. I hope that they will do that this year again. It will be third time, because in the past, I believe first time we had something like that in Los Angeles or San Francisco, last year in San Diego, and hopefully this year in Boston. My second comment is regarding doing research. One of the most popular venues to do research is using appropriate databases. One of those was included in one of presentations is national inpatient sample. So that would be done, and you can do that in your sites if they have license or if they purchased access to national inpatient sample. That access is approximately a few $100s, maybe $200 or $300 per year, if student applies for that specific research. And database is huge. You have access to millions of data about millions of patients in US hospitals. And if you can on PubMed, if you can use words national inpatient sample, you can see hundreds of papers. And that is very easy. And if you find access, I can help you with further steps. Thank you very much. Again, congratulations, Rachel. Congratulations, Jamal. Great Saturday morning, particularly because Iga Świątek won French Open. So, but instead of watching, I was present here, so I didn't watch.
Oh, thank you, Dr. Nikki, for that. Like I said, thank you very much, everyone, for joining us today. This is the first of many research symposiums from SMSIG. We will keep you updated on any research that we have going on as part of the club, or any updates in terms of other research symposiums or seminars on how to do research, how to get involved in research. And again, if anyone has any questions regarding any research, please reach out to me. I'm more than willing to help. There's plenty of research opportunities for anything that you're interested in, whether it's general surgery, neurosurgery, orthopedics, et cetera, please feel free to reach out to me, and I'm more than happy to help. And with that, I think that concludes our very first inaugural research symposium. So we will end it on that note. Thank you so much, everyone, for joining us. Dr. Heron, Dr. Nikki, Rachel, all of our attendees, and all of our presenters. Thank you so much.
Thank you, everyone. Thank you, Dr. Heron. Thank you, Dr. Renicky. Thank you, Jamal, for putting it on. And all of our attendees for presenting. It was really fantastic, and I had a really great day.
Thank you.
Take care,
Thank
everyone.
you, Dr. Heron.
I know.